Hello everyone. Welcome to the Targeting Pain and Prescription Opioid Misuse with Mindfulness-Oriented Recovery Enhancement webinar. We're glad you're here with us today. My name is Tanya Hyde and I'll be moderating the webinar today. I'm the project manager with the Canadian Institute for the Relief of Pain and Disability. And this webinar is made possible through the support of the Community Gaming Grant through the BC government, as well as donations and memberships to CIRPD. As I mentioned, my name is Tanya and I'll be moderating the webinar today and handling the Q&A session. And our presenter is Dr. Eric Garland. Dr. Garland is Presidential Scholar, Associate Dean for Research, and Associate Professor in the University of Utah College for Social Work. He's also the Associate Director of Integrative Medicine in Support of Oncology and Survivorship at the Huntsman Cancer Institute, and the developer of an innovative multimodal mindfulness-based intervention founded on insights derived from cognitive, affective, and neurobiological science. This is called Mindfulness-Oriented Recovery Enhancement, or MORE. He has received funding from the National Institutes of Health to conduct randomized controlled trials of MORE as a treatment for prescription opioid misuse and chronic pain. To complement his expertise in clinical research, Dr. Garland is a licensed psychotherapist with more than a decade of clinical experience working with persons suffering from addictive behaviors, mood disorder, traumatic stress, chronic pain, and psychosomatic conditions. Thank you very much for being with us today, Dr. Garland. I will hand it over to you.
Thank you, Tanya, for that really kind introduction. And it's nice to be speaking with all of you out there in this virtual world here. So I'm going to do my best to give you an engaging presentation, even though I can't see you and you can't see me. I wanted to talk with you today about the intervention I developed called Mindfulness-Oriented Recovery Enhancement, or MORE, and its effects on both pain and prescription opioid misuse. As you may or may not know, chronic pain is a staggeringly huge problem. Across the globe, more than one in 5 adults suffer from pain. And in America, chronic pain affects at least 116 million Americans per year. That's more than the total number of individuals affected by heart disease, cancer, and diabetes combined. This enormous problem also exacts a tremendous toll. Chronic pain costs an estimated $635 billion each year in medical bills, lost productivity, and missed work. To address this problem, the traditional medical system has attempted to use opioids to manage chronic pain. However, recent meta-analyses, and if you're not familiar, a meta-analysis is a synthesis of statistical data across a great number of studies. Recent meta-analyses suggest that opioids do not produce clinically important pain relief. So although individual patients may report some relief from opioids, on the whole, when examined across a great number of well-controlled studies, they don't seem to really provide very much relief at all. Nonetheless, the use of opioids has increased to a great extent, as has the misuse of opioids. Prescription opioid misuse has increased more than 300% over the past several decades. And recent estimates suggest that nearly 1/4 of chronic pain patients misuse prescription opioids. So what is opioid misuse? This is essentially the use of opioids in non-prescribed ways, such as taking opioids to relieve stress or anxiety, anger, or sadness, or taking opioids in higher doses than prescribed by one's physician. And new research suggests that both the use and misuse of long-term opioids significantly increases the risk of mortality. So this is a huge problem, but I think I offer you a story from my clinical practice. It may bring things into greater focus for us. So recently I saw a new patient. He came to me seeking help to deal with chronic pain. He had had a series of 5 failed back surgeries, and with each surgery had received escalating doses of opioids. He was still in pain. He knew the opioids were not a solution for him. He knew he was taking too much. But as he told me just poignantly, I just don't want to be in pain. My heart poured out to this gentleman. And I think to understand how we can help individuals like him, we need to understand the factors which undergird the problem of prescription opioid misuse among chronic pain patients. And notably, I think we need to focus on the process of hedonic regulation and dysregulation in this problem. So to understand this concept, I'd like to give you a little bit of background. So historically, in Western philosophy, pleasure and pain have been considered opposite poles on the balance of hedonic well-being, such that increasing experiences of pain come to outweigh the experience of pleasure in everyday life. However, modern neurobiological science suggests that these factors actually operate through a common emotional currency in the brain. In other words, both pleasure and pain are mediated by brain circuits that are essentially focused in the mesocorticolimbic dopamine system, as well as the endogenous opioid system. And these same brain circuits are activated and hijacked by addictive drugs. Multiple drugs of addiction, including alcohol, cocaine, heroin, etc., operate through this brain circuitry and co-opt this brain circuitry through an allostatic process in which repeated experiences of drug reward sensitize the brain and come to outweigh the experience of natural reward from healthy natural pleasures in everyday life, such as the sight of a beautiful sunset, the taste of a delicious, healthy meal, or the warmth of the hand of a loved one, or a hug from a family member. These natural rewards come to be less rewarding over time as an individual becomes further and further ensnared in the allostatic process of addiction. So to understand the role that hedonic dysregulation plays in the downward spiral linking chronic pain to opioid misuse, my colleagues and I developed a theoretical model, which we published several years ago in the journal Neuroscience and Biobehavioral Reviews. And the model goes something like this. The recurrent experience of pain eventually comes to lead an individual to fixate their attention on painful sensations in their bodies and to ruminate about the experience of pain. This attentional fixation and rumination then drives stress and increases negative emotions. When patients take opioids, the opioids may not only alleviate pain, but they also temporarily alleviate stress and negative emotion. And thus, through the process of negative reinforcement conditioning, come to strengthen the habit of opioid use. As this habit becomes stronger over time, individuals may develop an opioid attentional bias, that is, a hyperfixation of attention on opioid-related cues, like the sight of the pill bottle in the medicine cabinet each morning when one brushes their teeth, or the sight of the pharmacy where one picks up his or her opioid prescriptions. These opioid-related cues can drive opioid craving irrespective of the need to obtain pain relief. When patients take opioids, opioid use may not only alleviate pain and negative emotion, but may also temporarily alleviate opioid craving and thus further strengthen the addictive habit. In some patients, they may develop hyperalgesia as a result of recurrent use of opioids, sensitizing the brain to pain, as well as insensitivity to natural reward. leading to opioid dose escalation as a means of obtaining a sense of well-being, and ultimately resulting in the loss of control over opioid use that is characteristic of opioid addiction. Clearly, not all chronic pain patients who take opioids become addicted. That's actually a very small subset of patients. And as I reported to you earlier, new data suggests that only 1/5 to 1/4 of patients misuse opioids. But nonetheless, for a select set of individuals, this downward spiral process may get them into trouble. And to illustrate these hedonic dysregulatory processes, I'd like to discuss with you some data that's newly coming out of my lab. We employed an emotion regulation task that was designed to assess a person's ability to reappraise the meaning or significance of negative cues, negative emotional cues that were designed to induce feelings of fear or sadness or anger. This task also assessed patients' ability to savor positive emotional cues, that is, to enjoy the sense of pleasure that comes from looking at images representing pleasant daily experiences. In this task, patients were asked to either reappraise or attend to negative photographs, or to savor or attend to positive photographs. During the task, we measured psychophysiological responses. We were mostly focused on heart rate variability, which is an index of parasympathetic nervous system control during emotional responding. And we found that chronic pain patients who misuse opioids exhibit marked deficits in heart rate variability during the emotional conditions of the task. These differences were evident when chronic pain patients attempted to regulate their negative emotions and to increase positive emotions in response to positive cues, as well as when patients were viewing positive cues. However, I would note here that there was no difference in heart rate variability while patients were viewing negative cues. So this suggests that opioid misusing chronic pain patients showed deficits in emotion regulation and also deficits in the ability to respond emotionally to positive events and experiences in their lives, thus indicating hedonic dysregulation. So to address this problem, we need new interventions, targeted interventions. And to that regard, I developed Mindfulness-Oriented Recovery Enhancement, which is an integrative treatment strategy for hedonic dysregulation among chronic pain patients prescribed opioids. MORE aims to enhance 3 key therapeutic processes: mindfulness, reappraisal, and savoring. I'd like to give you a little background on each one of these therapeutic processes now. And I should add here that MORE is a manualized treatment. The treatment manual was published in 2013 to be used by social workers, psychologists, nurses, and physicians to help their patients suffering from addiction, stress, and pain. So for those of you who are not familiar with mindfulness, mindfulness can be thought of as a state of mind, a personality trait, and a set of practices. The state of mindfulness is a non-reactive, metacognitive state of awareness characterized by acceptance of and attention to feelings, emotions, and perceptions in the present moment. And to understand the metacognitive aspect of mindfulness, we often use the metaphor of observing one's thoughts and feelings as if they were clouds passing in a clear blue sky. In other words, you can attend to the thoughts and feelings as if they were objects external to oneself, as if oneself was not wrapped up in thoughts and feelings. Mindfulness is also a trait. That is, a disposition or personality propensity characterized by the tendency to observe one's present moment thoughts, feelings, emotions, and perceptions without reacting to them negatively or judging them. There are also mindfulness practices, which are techniques designed to induce the state of mindfulness. And I think that mindfulness can be profitably conceptualized as a state-by-trait interaction. That is, the repeated practice of engaging mindful states through mindfulness meditation techniques can ultimately lead to the development of mindful traits. In other words, a person can transform themselves through mental training to become more mindful in everyday life. I'd like to offer you this following quote by Shauna Shapiro, which I think illustrates quite nicely the metacognitive aspect of mindfulness. If we are able to see it, then we are no longer merely it. We must be more than it. Whether the it is pain, depression, or fear, metacognition allows one to disidentify from thoughts, emotions, and body sensations as they arise, and simply be with them instead of being defined by them. Through the metacognitive aspect of mindfulness, one realizes, this pain is not me, this depression is not me, these thoughts are not me. And another way to illustrate this concept is through this famous drawing by M.C. Escher. When one is holding the crystal ball, when one can see or observe one's pain from a metacognitive standpoint, one becomes free of the suffering. By observing the suffering, by locating your sense of the observing mind outside of the suffering, suffering becomes something external to you. You're no longer trapped by it. Mindfulness-oriented recovery enhancement also focuses on reappraisal as a means of coping with pain and negative emotions. Reappraisal may be defined as the process of reframing the meaning of a stressful life event, such as to see that event as benign or a source of growth or a learning opportunity. And this concept was heralded by the early Stoical views of ancient Rome. Epictetus said, "We are disturbed not by events, but by the views which we take of them." And Marcus Aurelius commented, "The universe is change. Life is what we deem it." So this capacity to reframe what the stressors in our lives mean and to see those stressors as not awful, terrible things, but rather as opportunities to grow and learn as a person, has been shown through modern psychological science and neuroscience to be a very healthy process. And a host of brain imaging studies have shown that reappraisal activates a wide array of brain regions, but most of the activations are centered on increases in the prefrontal cortex, which are coupled with decreases in activation in the amygdala, the part of the brain that processes fear and negative emotions, as well as increased activation in the nucleus accumbens, the part of the brain that processes experiences of reward. And these brain activations seem quite relevant to the issue of the intersection between chronic pain and opioid misuse, per our discussion of hedonic dysregulation, as mentioned previously. Lastly, mindfulness-oriented recovery enhancement focuses on boosting positive emotions and the sense of reward in everyday life through savoring. Savoring is the process by which we pay attention to the positive features of pleasant everyday experiences. But there is also a metacognitive element to this practice as well. When we savor, we can become aware not only of what is good that is happening around us, we can also become aware of our positive emotional responses to that event. And ultimately, we can learn to turn our attention inward and actually focus attention on and savor the positive emotions arising within us. And in this way, magnify the pleasure and the goodness that one can derive from the beautiful moments of our lives. One can savor very concrete things, such as the blueness of the sky and the ocean in this photograph, the dynamic movement of the seagulls swooping through the air. Or one can savor more abstract and socially, emotionally meaningful features of an experience. For example, the bond between father and son, sharing loved activities, and the deep meaning that comes from enjoying the wonder and mystery of the world. These too can become targets of savoring. And if chronic pain patients who misuse opioids have become insensitive to natural pleasure as a result of both chronic pain and prolonged opioid use, then perhaps this technique of mindful savoring may in fact restore the individual's ability to enjoy their lives and then perhaps decrease dependence on opioids. That is my hypothesis, and much of my recent work is in support of this notion. So MORE is a sequence treatment. It introduces the components of mindfulness, reappraisal, and savoring in a sequenced manner over time to modulate a number of therapeutic mechanisms to ultimately produce change in a series of treatment targets that are directly relevant to helping people overcome suffering caused by chronic pain and opioid misuse. MORE is typically delivered as a group therapy over 8 treatment sessions that occur once a week. The session topics here are listed on the left. Group sessions are about 1.5 to 2 hours long. They begin with a formal mindfulness meditation exercise, followed by a debrief and a group process session in which patients discuss their experiences using mindfulness, reappraisal, and savoring techniques to help themselves cope in everyday life. Following this, new psychoeducational or didactic material is presented. Sessions end with an experiential exercise, and participants are asked to practice homework consisting of 15 minutes of mindfulness, reappraisal, or savoring practice each day. Participants are also asked to practice 3 minutes of mindful breathing before taking their opioid medication throughout the day. And the purpose of this technique is to help patients to clarify whether their opioid use is being driven by a legitimate need for pain relief or perhaps driven by craving. The purpose of this technique is also to prevent unnecessary opioid dosing by providing a non-opioid means of obtaining pain relief. That is, obtaining pain relief through mindfulness. To understand how mindfulness can alleviate pain, please allow me to offer you this following illustration. Chronic pain patients typically experience pain as an emotionally laden, monolithic, solid, and unchanging thing. And on top of this, they may overlay a layer of suffering, saying to themselves, "Why me? This isn't fair. This pain is ruining my life." In MORE, patients are taught mindfulness skills which can be used to remove this emotional overlay and to decompose the pain experience into its subcomponent parts. So for example, patients are taught to attend to pain not as some overwhelming, anguishing, and awful emotional experience, but rather to focus on the specific sensations in the body, breaking down the experience of pain into sensations of tingling or pressure or heat. And coping with any one of these sensations may be more manageable than coping with the overwhelmingly monolithic and emotionally anguishing experience of pain as a whole. In More, a similar technique is used to help patients cope with the experience of craving. Patients are taught to use mindfulness to break down craving into its subcomponent parts. So for example, to attend to craving as sensations of jitteriness in the stomach, or perhaps an image of pills in one's mind, or maybe even noticing saliva in one's mouth. Now I'd like to talk with you about research on these techniques. I'm going to summarize results across a number of studies that are listed here. I conducted an NIH-funded randomized controlled trial of More as a treatment for chronic pain patients who are receiving long-term opioid therapy for pain. 115 chronic pain patients who had taken opioid analgesics for more than 3 months were randomly assigned to receive either 8 weeks of mindfulness-oriented recovery enhancement or 8 weeks of a support group led by a master's level therapist. Outcomes were assessed pre- and post-intervention, as well as at a 3-month follow-up. And assessments were quite comprehensive. They consisted of a psychiatric interview, a battery of self-report measures, a suite of cognitive tasks, a psychophysiological measurement protocol, and ecological momentary assessment, which is a big word that basically means measuring people's responses, including their pain and their mood state, multiple times a day through the use of symptom diaries. With regard to the characteristics of the sample, the majority of participants were middle-aged females who were predominantly white or African American. Most of the participants came from a low socioeconomic strata. They were employed part-time or not at all. On average, patients had been in pain for more than 10 years. And 72% were at risk for prescription opioid misuse, as indicated by their scores on a validated instrument. The most common pain condition reported by the sample was low back pain, followed by fibromyalgia. And participants in the study reported a wide array of psychiatric difficulties, including major depressive disorder and generalized anxiety disorder. With regard to the findings, we found that More led to significantly greater reductions in pain-related functional interference than the support group. And these effects were strengthened by the 3-month follow-up. Pain interference is a measure of how much pain interferes with a person's general activity level, their mood, their walking ability, normal work, relations with other people, sleep, and enjoyment of life. We also found that More led to statistically significant yet modest reductions in pain severity that were strengthened by the 3-month follow-up. And we found that the effect of mindfulness-oriented recovery enhancement on reducing pain severity was statistically mediated by increasing the capacity to reinterpret pain as harmless sensory information, as well as increases capacity to be non-reactive to distressing thoughts and emotions. In other words, More seemed to reduce chronic pain severity by teaching people how to reinterpret the sensations from their body as pure sensation rather than as an emotionally anguishing, awful event. And I would add that this finding is a replication of earlier research from my group. We studied mindfulness as a treatment for irritable bowel syndrome, which is also another functional chronic pain condition. And we found that the effects of mindfulness training on reducing abdominal pain in IBS patients was again statistically explained by increases in the capacity to reinterpret pain as harmless sensory information and increases in the capacity to be non-reactive to distressing thoughts and feelings. And converging findings across these two studies with these two different pain samples suggest that these factors may indeed be therapeutic mechanisms of mindfulness. With regard to the opioid-related outcomes, we found that mindfulness-oriented recovery enhancement significantly reduced craving for opioids, irrespective of changes in pain severity. So, aside from the effects of more on pain severity, the intervention seemed to reduce craving for opioids. And, notably, mindfulness-oriented recovery enhancement led to significantly greater reductions in opioid misuse than the support group. There was a 68% decrease in opioid misuse in the mindfulness-oriented recovery enhancement group, compared to a 32% decrease in the support group. Now, I conduct, in addition to clinical research, I dabble in neuroscience, and I use neuroscience measures to help assess the factors that might explain the linkage between chronic pain and opioid misuse. So, specific to today's talk, I employed a dot probe task to assess attentional and autonomic indices of hedonic regulation. And hold on to your lunch, because I'm about to show you a fairly graphic photograph. In this task, participants are presented with a computer screen that's split in two. On one side of the screen is a pain-related photograph, and on the other side of the screen is a neutral photograph. These photos are presented for a brief amount of time, either one-fifth of a second or 2 seconds long, and then they disappear and are replaced by a dot. The participant's task is to choose the side with the dot. If the dot shows up on the left-hand side of the screen, participants press the left arrow. If the dot shows up on the right-hand side of the screen, participants press the right arrow, and the computer measures reaction times. It turns out that a large body of research suggests that chronic pain patients are faster to find the dot when it replaces a pain photograph relative to when it replaces a neutral photograph. And this provides an objective index of attentional bias, or how fixated a person's attention is on pain-related information. In the present study, we also employed pairs of neutral photographs and positive photographs, naturally rewarding photographs, and pairs of opioid-related photographs and neutral photographs. And incidentally, I conducted some earlier research that showed that chronic pain patients who misuse opioids are faster to find the dot when it replaces an opioid photograph compared to when it replaces a neutral photograph. In other words, opioid misusing chronic pain patients show an attentional bias or a fixation of attention on opioid-related cues. So we wanted to understand to what extent can mindfulness-oriented recovery enhancement change attentional and physiological responses to these types of cues. And we found that more led to significant reductions in the pain attentional bias. And individuals who showed the greatest decreases in the pain attentional bias felt that they had the greatest ability to control their pain. We also found that more led to significantly greater reductions in the opioid attentional bias than the support group, and that patients who showed the greatest decreases in the opioid attentional bias also showed the greatest improvements in opioid misuse across treatment. During this task, we measured autonomic responses, namely heart rate, and we found pretty dramatic results. I don't think you really need to know statistics to see that something big is going on here in this graph. So let me just take a moment to break this down for you. The mindfulness-oriented recovery enhancement group is represented by the blue bars, and the support group is represented by the red bars. Here you can see that across all three cue conditions, mindfulness-oriented recovery enhancement led to significantly greater decreases in heart rate response during cue exposure. However, there was no difference in heart rate response during the resting baseline. This suggests that mindfulness-oriented recovery enhancement doesn't produce a mere relaxation response, but rather changes one's emotional response while paying attention to emotional information. And to understand what this means, we asked patients to rate how arousing they felt the photographs were. Not surprisingly, decreases in heart rate response to the opioid photos and the pain photos were correlated with decreased arousal to those photographs. In other words, patients felt less stimulated by the opioid photographs and the pain-related photographs, and evidenced greater heart rate decreases. However, we found the opposite pattern to the pleasure photographs. Patients who showed the greatest heart rate decelerations to the pleasure photographs reported the greatest increases in arousal to those photographs. In other words, they reported being more stimulated by natural pleasure. And we conducted a heart rate variability analysis and found a similar pattern, that across the board, the Moore group showed significantly greater heart rate variability to all three cue conditions, but this effect was most pronounced to the pleasure cue condition. To understand what this means, we conducted a multivariate path analysis and found that the effect of Moore on reducing opioid craving could be explained by changes in heart rate response to the pleasure cues, not to the opioid cues. In other words, Moore seems to reduce opioid craving by enhancing heart rate responses to pleasure cues, suggesting that Moore may reduce opioid craving by enhancing natural reward processing and reversing the hedonic dysregulation implicated in the downward spiral linking chronic pain to opioid misuse. And we found converging support for this hypothesis in our EEG data. We conducted an EEG analysis while patients were viewing naturally rewarding, pleasurable photographs, and found that Moore led to significant increases in EEG response while viewing naturally rewarding photographs compared to the support group. This increase in brain response to naturally rewarding photographs was correlated with reduced opioid craving, again suggesting that mindfulness-oriented recovery enhancement increases physiological sensitivity to natural pleasure, and that by doing so, this may reduce an addictive propensity towards opioids. We also found that patients who showed the greatest increase in brain response to natural pleasure reported the greatest decreases in pain severity, suggesting that teaching patients to savor what's good in life may actually provide a means of helping them to cope with pain. And as I indicated earlier, we ask patients to fill out diaries each day to record their level of pain and their mood state throughout the day over the course of the 8 weeks of treatment. And we found that mindfulness-oriented recovery enhancement led to significant decreases in pain intensity and significant increases in positive emotions over the course of treatment. Not only that, patients who received mindfulness-oriented recovery enhancement were better able to regulate their moods and keep their moods stabilized towards a positive mood state. This ability to increase and stabilize one's mood towards the positive was predictive of opioid misuse. Patients who no longer misused opioids by the end of treatment also showed the greatest increases in positive emotions over the course of the Moore therapy. And I want to mention to you some other data from a different application of Moore, which is directly relevant to this hypothesis that increasing sensitivity to natural pleasure may reverse the hedonic dysregulation inherent in addiction and provide a potential treatment for addictive behavior. So this data comes from a study conducted by my colleagues and I. This is an fMRI study doing brain imaging of nicotine-addicted smokers who received mindfulness-oriented recovery enhancement. And these patients were asked to participate in fMRI scanning while viewing and savoring naturally rewarding positive photographs. And we found that following training with mindfulness-oriented recovery enhancement, individuals showed heightened brain activation in the ventromedial prefrontal cortex and the ventral striatum while savoring naturally rewarding photographs. In other words, areas of the brain involved in pleasure and reward became hyperactivated while patients were savoring the positive aspects of the photographs. And these increases in brain activation were correlated with decreased cigarette smoking. So patients who showed the greatest activations in brain regions associated with processing pleasure and reward showed the greatest decreases in addictive tendencies towards cigarettes. This data suggests that more may train people to become more sensitive to natural pleasure, thereby shifting the relative salience or importance of drug reward compared to natural reward, such that increasing experiences of natural reward in everyday life come to outweigh the importance of drug-related reward. In conclusion, the data suggests that more may be a promising treatment for chronic pain and prescription opioid misuse, and that more may ameliorate opioid misuse by strengthening the hedonic regulation of pain, craving, and reward. New studies, including molecular neuroimaging and neurogenetic research, are now needed to elucidate the effects of mindfulness-oriented recovery enhancement on brain systems relevant to chronic pain. Ultimately, more may disrupt the downward spiral linking chronic pain to opioid misuse and stimulate an upward spiral linking mindfulness to meaning in the face of adversity. I'd like to thank you for your time and attention, and if you're interested in becoming trained in more so that you can help other patients suffering from chronic pain, please see my website or send me an email. Thank you very much.
Wonderful. Thank you very much, Eric. That was really great. And it's not an issue because we have a lot of attendees who are in Canada. It doesn't matter whether they're in Canada or in the States in regards to training?
No, but the next training will probably be held in Salt Lake City.
Okay, so willingness to travel would be required.
That's right.
Okay, great.
I'd consider setting up training in other places, including Canada, but the next training will probably be here.
Okay. Let's see, now to get to a few questions. So there was a question, is there a linkage between mindfulness and neuroplasticity?
My short answer is there certainly seems to be a link between mindfulness and neuroplasticity. There have been a number of studies in the past several years suggesting that practitioners of mindfulness meditation show larger gray matter volume in regions of the brain associated with regulating and shifting one's attention and regulating one's emotions relative to people who don't meditate. Of course, there are some problems methodologically with those studies because we don't know whether mindfulness meditation increases brain volume or whether people with bigger brains just tend to meditate more. So that's sort of a conundrum for the field. And to answer that question, we need to do longitudinal studies where we take meditation-naive participants and follow them over time and do multiple measurements of brain volume and connectivity to see how the brain changes in shape and structure over time. And in fact, some of these studies are being done now, and several of them point to the fact that, yes, indeed, mindfulness meditation can stimulate neuroplasticity. But of course, more research there is needed.
Interesting. All right. And there was someone who said that it was a great presentation. They were wondering, however, about the quote-unquote boosting positive emotions, if one is part of a marginalized population or living in poverty, complex trauma linked to pain, those types of complicating factors.
So the question is, how can one boost positive emotions for vulnerable populations who have been marginalized and facing complex trauma? Is that the question?
I think so. Essentially just addressing, is it harder or more difficult considering more complexities around not just chronic pain or addiction?
I mean, I guess I would think that, of course, these are obstacles and major stressors which can make it difficult to achieve and maintain positive emotions. But then again, on the other hand, many individuals show remarkable resilience in the face of complex and prolonged adversity. And the capacity to reframe the meaning of adverse life events, such as trauma or marginalization, this ability to reappraise or positively reappraise such adversity is really a key to resilience. And actually, just yesterday I heard the Dalai Lama speak about his experiences of marginalization in Tibet and the oppression of the Tibetan people. And he actually presented a remarkable positive reappraisal. He spoke to the several hundred Tibetans in the crowd and told them that although they had suffered a great deal, that they should view their suffering as an opportunity to teach the world about their culture and an opportunity to show strength in the face of suffering, and that by doing that they would become more compassionate, more sensitive to others' suffering, and be able to help them more. So I think that of course I'm not underestimating the massive stress that's involved in being a marginalized person or a victim of complex trauma. But I am suggesting that even in the face of some of the most severe traumas, the human mind is inherently capable of transforming itself and showing resilience and actually deriving a sense of meaning or higher purpose from facing those adversities. I think that was the Dalai Lama's point, and I think that offers hope to people no matter how difficult their situation.
Very good. There was someone wondering, do patients need to agree they have a misuse problem in order to participate in more?
That's a very good question. We have, thus far, we've been offering more to very mixed groups of patients. So in these groups, we've had patients who are definitely adherent to the prescription regimen prescribed by their physician, as well as patients who are full-blown addicts who may have even been in formal addictions treatment, and then everywhere in between, the various shades of gray, from people who take medication mostly as prescribed to people who take medication barely as prescribed. So these mixed groups have presented a challenge for us in terms of how to pitch these techniques to most effectively address the issue with people at varying motivational stages and recognition of a problem. And I think the bottom line is the way we've worked it, and this seems to help, is to focus on pain in the beginning. So we ask patients, are they satisfied with their pain relief that they've been achieving through the traditional medical strategies that they've been trying? And of course, most of these patients report that no, they're not getting adequate relief. That's why they're seeking extra help. So we present the skills of mindfulness and reappraisal and savoring initially as ways of coping with pain. Only after time, when the patient has experienced some success in using these skills to help themselves cope with pain and the stress of everyday life, then as we begin to develop trust and a positive working relationship, then we can gradually and gently introduce the concept of physiological dependence on opioids, and then the possibility of psychological dependence on opioids. And if the patient connects with these issues, then we can teach them the techniques of mindfulness, reappraisal, and savoring to help them deal with those issues. So we start with the open door of pain, and then as we build trust and connection, we can address some of the other issues that may be harder to talk about.
Very good. And then someone asking if you run across patients who maybe start the program and then drop out because they can't do it, or other like resistant patients to change and to
definitely. So in our studies, we've seen a dropout rate of around 20%, and clinically, I would say the dropout rate is that high or higher. So it's definitely an issue. This is not easy work. And unfortunately, I think that many people are out there looking for a quick or easy solution. But pertaining to the very first question that was asked of me about neuroplasticity, I don't think neuroplasticity can really occur without intense effort and dedication and repeated practice. And some people may just not be ready for that. So yes, the dropout and the motivational issues are certainly a challenge to working with patients suffering from pain and opioid-related problems. And again, my heart goes out to these folks, like the individual I spoke about at the beginning of my talk. It's really difficult to cope with pain over years. It's demoralizing and demotivating, and it hurts. So I sympathize greatly with patients suffering from this problem, and I hope to develop new and better means of engaging motivation so that patients can practice these skills, which when practiced diligently, I think can really produce some positive results.
All right. And then there's someone wondering, have you found that function improves with more, and any studies around this?
Yes, so we published a paper in the Journal of Pain and Symptom Management a couple of years ago looking at the effects of more on function. Now, I would add here that this is all self-reported function. We haven't yet put patients through some sort of objective functional tests. So this is all just according to the patient's perception. But yes, mindfulness-oriented recovery enhancement does significantly improve function and reduce disability caused by chronic pain symptoms as reported by the patients themselves.
Great. And then besides pleasure dysregulation, what are other pathways in which opioid misuse slash use can affect the brain, and also other pathways in which mindfulness affects the brain?
Yes, I focus mostly on this issue of hedonic dysregulation, which most closely ties to pleasure, but it also ties to pain and negative emotions. And so because the hedonic systems in the brain regulate all three of these things, pleasure, pain, and negative emotions. So studies, there is not a great deal known about prescription opioids and their effects on these processes yet. Believe it or not, we've been prescribing these drugs for decades, but we haven't really gotten a full handle on how they change the brain in chronic pain patients who use and misuse opioids for a long period of time. But the new data that's emerging suggests that chronic opioid use decreases sensitivity to pleasure and increases sensitivity to negative emotions and pain. So I think those pathways, all three of those pathways are quite relevant. And then the other neurobiological mechanism that I think is really important in understanding this condition is understanding how long-term prescription opioid misuse changes habit circuitry in the brain. And these effects are most likely very similar to the effects of other psychoactive drugs in the brain, changing, for example, the ventral and then ultimately the dorsal striatum involved in encoding and executing habit behaviors. So opioid use, when prolonged, can become a habit, just like smoking cigarettes or drinking alcohol or overeating. And once it becomes a habit, it becomes automatized and difficult to control because it's not as subject to conscious regulation. And that's where mindfulness really fits in. And so the second part of the question was about what other pathways seem to be promising means by which mindfulness produces therapeutic effects. And that's a pretty big subject, but let me just summarize it by saying that mindfulness seems to enhance brain circuits involved in controlling one's attention, regulating one's emotions, and increasing awareness and control over automatic reactions, including automatic habits. So because mindfulness seems to produce these effects, these therapeutic effects on positive and negative emotions and automatic habits, it seems like a pretty logical treatment for chronic pain and prescription opioid misuse. Oh, and lastly, I forgot to mention this, but there's also been quite a bit of research on mindfulness, on the effects of mindfulness on reducing pain responses in the brain, and some dramatic effects have been shown with regard to that effect of mindfulness as well.
Wonderful. Okay, so we are out of questions as well as out of time. So thank you so much, Eric, for the presentation and for your information. It was very, very interesting and also a good balance of technical as well as practical information. I really appreciate it.
Great, it's my pleasure.